podcast. It is March 14th, 2017. As I begin the webinar tonight, most importantly, I want to ask you for your questions, because I think this is probably something that most of our participants can relate to, and that is dealing with an oppositional child, or a child that's struggling with acting out rebellion type behaviors. And also, it's of a significant concern for most of our families when their child demonstrates a lack of empathy. So I would like to hear your questions about it, because I have some diagnostic criteria that I'm going to visit. I'm not going to read it word for word, because anybody can look that up on the web, but I just want to give you some idea of the different categories and what we think those different categories mean, or what they indicate about what the child might be going through. So with that preamble, please submit any of your questions ahead of time to Andrea, my moderator, and she'll pass those on to me when it's the appropriate time later on in the webinar. So I'm going to talk about oppositional defiant disorder. I've actually heard it said by some that there's no such thing, that by nature most children are oppositional. But like with most diagnoses, it really becomes a matter of gradations. Does it begin to interfere with several spheres of their life? Is it developmentally inappropriate? And for all of these things, I want to warn very, very carefully that there are some of these criteria that are common in all children. All children are going to struggle, or at least most children are going to struggle with some of these themes, some of these issues. So I think, and I'll talk about this when I do the take home later on, I think it's imperative that people get help, that you have an outside professional, especially because a lot of people will report a very different kind of behavior, or a very different kind of response to authority inside the home as compared to outside the home. So you begin to learn what kind of systemic dynamics are possible. And that's more than just cause and effect. I think a lot of people, when they hear about that, when a parent hears about that, because of all of the responsibility that we feel and the guilt that comes along with a lot of us, that when we hear people talk about it's different inside of the home versus outside of the home, we immediately hear that I'm causing it, that somehow I'm some kind of bad seed or bad creator of this behavior. It's more complex than that. It's a dance. It's a way that families begin to communicate with each other through rebellious behavior, through oppositional behavior. So it's very important that you open yourself up to, and those of you, of course, watching this webinar have done that. It's very important that you understand from somebody else, from somebody outside the system, where your child might fit on that, and what might also be going on in those behaviors. We'll talk about these in terms of severity. Oppositional defiant disorder is the lesser of the two. Cognitive disorder, as we talk about later, starts to border on a significant lack of empathy, vindictiveness, and acting out toward people or animals, or a lack of empathy in those situations. So when we talk about oppositionality, we talk about irritable mood, losing the temper, easily annoyed, easily angry and resentful. And again, even typical adolescents and pre-adolescents can have some of these, but these start to get so disruptive to the daily routine that it becomes difficult. They often argue with authority figures. They often defy or refuse to comply with rules or requests from authority. Deliberately annoying others, often blame others for their mistakes or misbehaviors. A second category is argumentative and defiant. Like I said, they argue with authority figures. They actively defy rules, defy others, blame others for their mistakes or behaviors. Excuse me, the last category is vindictiveness. Has a spiteful or vindictive disruption, acting out period that gets stuck. It's kind of like being in a rut, right? They're committed to it. There's nothing you could do. The more you heap consequences on them, the more that they can stay stuck in it. We even see that in our program sometimes, that our program becomes this point where parents intervene and a child can dig their heels in. So there's definitely a stuckness to it. The disturbance in behaviors associated with distress in the individual or others are in her immediate social context, family, peer group, or colleagues. It impacts negatively on social, educational, occupational, or other important areas of functioning. And with all diagnoses, folks, that's the key. Does it disrupt the spheres of our life? We all can identify some of the various characteristics in a lot of the mental health diagnostic categories, but is it so much so that it's getting in the way of my functioning in these various areas in life. It does not, of course, occur. It's not in relationship to psychotic, substance abuse, depressive disorder, or bipolar disorder. Another important part that we'll talk about is that it's not associated with reactive attachment disorder. That's something fundamentally different. And unlike children with conduct disorder, with ODD, children with oppositional defiant disorder are not aggressive towards people or animals, like I mentioned earlier. They do not destroy property and do not show a pattern of theft or deceit. A diagnosis, of course, is not necessary when you already have reactive attachment disorder. And I know some of you have children that suffer from reactive attachment disorder, where there's been a significant break in early childhood attachment. And these individuals can be incredibly provocative. And like a lot of diagnostic categories, one of my favorite concepts in all of psychology is this idea that they're committed to you losing, right? You're going to lose. And when you have it in your mind that you can possibly win, you're in it with them, right? You're stuck in it with them. So what I say, what's been told to me, what has been taught to me that I share with you, is this idea that in these cases, you recognize that you can't win. You can only choose how to lose. I think that's one of those gems in life. And so you choose to lose with as much patience as possible, as much clarity as possible, as much integrity as possible, right? You start to identify your core values in responding to your child with ODD or conduct disorder or bipolar or borderline personality disorder or substance abuse disorder. You start to respond to them from a place of your core values. And you stop responding to them from the perspective of, I can solve this puzzle. I can make this go away. Ironically or interestingly, by responding from that place of authenticity, by removing yourself from that unintentional dance, that dance that unintentionally reinforces the behavior, you actually become more effective in contributing to it going away. So I'll say that again to be clear. When you pull yourself out of that dance of trying to fix it, trying to solve the puzzle, when you get back instead into your core values, what is your truth? How can you be authentic? When you do that, you are much more likely to contribute positively to the situation. So there's a letting go, right, of this entire process. It's a lot of what I talk about in a lot of our parenting work, right? You let go, you trust your throw, you trust your swing, you trust the truth, you trust your authenticity. And you recognize that I can't win, but I can choose how to lose. And I'm going to choose to lose with my core values. Conduct disorder is more significant. It's a repetitive and persistent pattern of behavior in which the basic rights of others are violated. So it's a more personal kind of acting out. It's not defying against behavior, it's trying to hurt somebody else. Aggression toward people and animals, they often bully, threaten, or intimidate others, and initiating physical fights, oftentimes identifying, collecting, getting weapons. They become physically cruel to people, physically cruel to animals, stolen. Theft is a theme in this, has forced somebody into sexual activity. Right? Those are pretty significant attributes. That's more severe. It's the precursor to what I'm going to describe in a moment, which is antisocial personality disorder. And there's hope for these, right? There's hope. But the more severe we get along this continuum, the more important it is for a parent to realize this is a long-term intervention. This is more than just acting out. And a lot of your children act out. This is a diagnostic category that becomes a theme in their life. It's a personality structure that's emerging. It's a sensibility, a way of being in the world with other people. And I'll talk a little bit later when I talk about treatment and response. I'll talk about the counterintuitive way in which we can respond to these individuals who are struggling with this. In terms of antisocial personality disorder, this, you have to be an adult, first of all. I'll say that. It'll mention that later on. It's a significant impairment in personality functioning manifested by poor self-functioning, very self-centered. It's not just narcissistic, but it has that quality to it. They struggle with self-direction, goal setting. It's everything is for personal gratification. There's an absence of pro-social standards, right? An absence of moral development, recognition of others and their basic needs, a lack of empathy, an inability to create intimacy is present with it. Also present are antagonism that are antagonistic behaviors that are characterized by manipulativeness, deceitfulness, callousness, and hostility. There's a disinhibition characterized by being irresponsible, impulsive, and risk-taking. So they have a disregard for anything and anybody's safety, right? And again, this is something that becomes cemented in young adulthood, becomes cemented in adulthood, but we see the signs of those leading up to adulthood. They're relatively stable across time. The impairments in personality functioning and the individual's personality trait expression are not better understood as normative for the individual's developmental stage or social cultural environment. So we understand that in certain situations, some of these behaviors, you can imagine in some other cultures, some of these behaviors might be present and might not be diagnostic. It's not directly related to substance abuse, but people that struggle with substance abuse can have a lot of these exact same traits. So for those of you who have children that struggle with substance abuse disorder and you see a lot of these characteristics, they wouldn't qualify for this if they were related to their substance abuse disorder or general medical condition, of course. And of course, the individual has to be at least 18 years of age. And we say that because these are very significant labels to put on people. And we want to make sure that there's a stable, consistent pattern of behavior. And they're most likely, like all personality disorders, they're more likely to be themes throughout their life than something that's totally eradicated. I remember talking to one young man that was turning 18 and looked like he was ending up like this. And we were actually going over his testing, which is not something I would do often. And it was a very sensitive moment because I was aware of the weight of this. And at one point, he asked me, he said, "Why are you sharing this with me?" Because he was aware this wasn't a common practice of mine. And I said, because this is going to require a kind of vigilance for you. This is going to require an awareness. There are certain diagnostic categories like bipolar, for example, or other personality disorders, where an awareness of your proclivities, awarenesses of your tendencies, of the themes in your life, is necessary for you to be able to mitigate those, to be able to not get into the same old patterns. So being aware of this in oneself, and it's very difficult for individuals who suffer from this to be aware of it because it's outside of their experience. They're likely to marginalize you and make it about you, right? They have a difficulty responding to other as a person. And I'll talk about that when I talk about treatment in just actually right now. I want to talk about empathy and objectification. This is a very simple model because most of us, when we think about empathy, when we think about somebody who commits a crime against another person, and we think about approaching that person or having a discussion, or if you're not a therapist, what would you say to somebody like that? I think most people imagine themselves talking to that person about how they affected the other person. Well, that doesn't work in this personality structure because the other person doesn't see the other person as another person. And this is how it develops. Through some exposure to some kind of discomfort or pain. It doesn't have to be severe, although it can be. The person learns to numb themselves, to not feel. In other words, they turn themselves into a non-feeling object. I turn myself into a thing to survive it, right? And then most human beings can only imagine something relatively similar to themselves. So when I see other people, I see them as things like me, non-feeling objects like me, because that's what I've either been turned into by somebody else through severe abuse, or I've turned myself into it to cope. So I see you as essentially a thing that doesn't feel, because I don't feel. And so then I treat you like an object. And now I'm not hurting somebody, I'm hurting a thing, and it's hard to feel guilty for hurting a rock, for example. Right? I don't have a lot of empathy for a rock because it doesn't feel. So the interesting idea that we can extract from this concept about how it develops in the self is that how do we teach people to have empathy? We teach them how to feel their pain, everyday pain, everyday hurt, everyday insecurity, everyday sadness, everyday grief. You can find the big fish. A lot of parents want to identify that big fish. Was it the divorce? Was it the bullying? Was it the learning disability and feeling ostracized in school? Right? Was it that I worked too much? Was it that we fought too much? They ask all those questions, like looking for that big fish. But what we say is, we're going to teach your child how to feel, and they're going to tell us the story. And the worst things haven't happened to them yet. For most children, unfortunately, or fortunately, I suppose, however you look at it, but the fact is that a lot of pain is yet ahead in their life. The most difficult and painful things have not happened yet in their life. So they're going to have to learn how to feel. And then when you learn how to feel, when one learns how to feel, you recognize feelings in others. And I've seen those moments. I've seen those with children. I've seen those with adults, where they've learned, after a significant amount of therapy, where they've learned to feel. And then they can start to identify, start to be sensitive to that same process in somebody else. So that's how we reverse this. And the wonderful thing that all of these oppositional disorders do is they do a fantastic job of first distracting the individual suffering, and then the person responding, they do a great job of distracting the person who's responding to them from the feelings, like a lot of disorders, right? They don't know how, they're not capable of talking about their feelings, and they develop this shield that distracts everybody. And so people can become so hyper focused on the eating disorder, the weight, the food, the drugs, the acting out. And it's so triggering. It's so hard not to think that way. And then they become, like I said, a distraction for everybody, the entire system. So behavioral therapies, including cognitive behavioral therapies, can be helpful. At times, they can be helpful. I've read from one professional dealing with it. When you're talking about somebody who's dealing with oppositional defiant, you need an uncorruptible, kind of perfect system, ideal system of reinforcement. Right? That's what you need for people struggling with these. So you need reinforcements and rewards that aren't reactive, that don't have in themselves their own vindictiveness. Family therapy is really critical, because it's critical to pull apart the function of the symptom, right? I talk about in my book, in the behavioral chapter, it's important that we first, before we try to change a behavior, that we listen to what that behavior might be telling us. And that's what I talk about, developing new hearing, new abilities to hear, new ears, new eyes for our children. And it's so perfect, because their behaviors are so fantastically designed to trigger us as parents, right? The teacher raises the child who drops out of school. The police officer raises the child who breaks the law, right? They find ways to rebel against the system that they were raised in. So family therapy is important to take apart the system and to understand what's going on. What is that behavior? How does it fit into this context? And avoiding the power struggle. I've said this, and I'll talk about this on the take-home slide. It's critical that we get outside help, because we're so triggered. We're compromised as parents. And with your children, even at Evoke, we get triggered by your children. They're fantastic at finding the buttons, finding the vulnerable spot in other people, and pushing them. It's It's second nature to them. It's more complex than a simple moral failing, right? We could talk about this in terms of moral development. That is a reasonable model to apply to this, but it can be more complex than that. The function of the symptom, what does it serve? What's its context, right? What's the structure of the self that's beneath all of this? Is this about poor attachment? Is this about objectification? Is this about identity? Right? Is this about some dynamic between parent and child? All of those questions need attention. And of course, the most important thing and the hardest probably to do is to provide empathy. You know, those you've heard these quotes before, that the children or people in the world who need love the most are sometimes, oftentimes, the ones that it's hardest to give to them. And that's why, again, an outside person can be helpful. And by the way, there's another advantage to being an outside person outside of the family, is that we have more resources at Evoke, for example, right? We have staff. We're working in shifts, if you will. And because these themes can be so strong and so entrenched, it can be absolutely exhausting. So I offer that hopefully to give those of you, all of you, kind of this self-forgiveness, that you're designed to fail at this, and that you absolutely need somebody from outside the family system to help you, to support you, to intervene, to get in there. Getting treatment is important. Getting assessments early, finding out what's going on. How serious is this? Am I seeing it clearly? Because another thing, I can't tell you how many times over the years, when I get a report from a family about their child, there are so many times when the parent is underreporting the severity of the issue. And there's an equal amount of times when the parent is over-reporting the severity of the issue. And so sometimes that's because of context, because the situation changes with context, but we're so close to it as parents, as family members, right? We're so close to the forest that we can't see the tree. So getting outside help, and that's not about being a failure, that's about being wise. That's about being confident and secure enough to say, I need help. I need somebody outside of this to give me some clarity and give me some perspective. Family work is, of course, is important. Finding out what's beneath it, what's underneath it, learning how to avoid the power struggle, learning that shame. You know, the interesting thing about this is that oftentimes these oppositional disorders are the result of shame, right? They're so shame-based that they throw the entire baby out with the bathwater. I'm going to defy every social norm because I'm so sensitive to and overwhelmed by guilt and shame. And so applying that to them doesn't help, right? It feeds it. And the hardest part about guilt and shame is it has such a wonderful, at times, temporary effect, right? Temporarily, people can respond to it, so we're tempted to use it. But shame is the cause of it. I can't tell you how many times I've told a father or a mother, and I've said, you know, your son wants nothing more than just to please you. And the parents, incredulous, will respond to me saying, what are you talking about? They're defying every family value, every family rule that we have. And my response is, that's just overcompensation. They're so afraid to fail that they'd rather try and fail. And so that's often part of the dynamic, and it's not intuitive, and it's not easy to see when you're in it. It's very easy to get locked into it. Responding with anger, intimidation, physical punishment, all are associated in the research with oppositional disorders, with defiant disorders, conduct disorders, right? So if we use these things, although they at times can feel cathartic to a parent because it's a release of your anger, at times they can have temporary effects, so we get reinforced by that. But what we know from the literature is they're also very, very common in families that struggle with these issues. And then, of course, any kind of reactivity, right? Any kind of knee-jerk. That's why you need support. That's why you need time out. That's why your child needs time out from you. To be able to operate from that that higher place in our brain, that more rational part of our brain, not the fight or the flight part of our brain. And then just remember that these are long-term themes. These are not often easily eradicated. And so knowing that it sets a pace for you, right? And oftentimes when you first start to intervene, like at Evoke, you'll see an increase in the behavior. We call that an extinction burst. Just like when you stop responding to a child's tantrum, what happens? Well, the first thing that happens in almost all cases is the tantrum increases first. So this is the long game. And again, having some support from outside of the family is essential to being able to maintain your stability, your endurance in the process, and pacing yourself. That this is not going to be a one-time kind of kick in the pants issue, that it's deeper than that. Can I speak about the first question I have tonight is, can I speak about the connection between guilt, shame, and empathy? I've said it a little bit already, and this question may have been posted a little bit earlier in the broadcast, but empathy is not from being guilted. It's not from simply recognizing how we've hurt other people. It's from learning to feel and developing a sensitivity around that, around oneself and then around others. And guilt and shame are overwhelming. Guilt and shame are toxic and tend to cause us to not respond in healthy ways, not in the long run. We feel bad. And when you're bad, what do bad people do? They do bad things. Right? I'd rather just be bad and just give up on trying because of how I feel. Brene Brown says in one of her talks that shame is associated with addiction and mental health issues, and guilt is not. I talk about this in my book. That's absolutely not true. Guilt and shame are present with, comorbid with mental health and addiction issues. They're not helpful. And they can't be relied upon for a consistent source of what is right, what is morality. Right? So we don't mental health is not about, I have had people walk up to me at the end of a presentation or at the end of a parent meeting and ask me about something from a religious context, something from their rabbi or their priest or their pastor. And I welcome that discussion, but part of what I also have to do is change the frame, right? Because we know from psychology, we know that guilt and shame are destructive. We know that they lead to mental health issues. We know that they're not consistent indicators of right and wrong. We know that they're oftentimes laden with family, unspoken family messages from our family of origin as parents, and then inadvertently passed down. So teaching people how to feel, that's the key. Teaching your children how to feel, holding that feeling for them, and developing enough capacity to do that. And that takes a lot of work. The next question, can a child with ODD be effectively treated without involving the parent? It's a great question. Of course, that's possible. Yes. I think understanding the parent and the family system. We work with young adults, sometimes not so young adults. And parents will always ask us, is it that relevant? And part of what our answer is first of all, the parent still is the original context. Even if they're an adopted parent, if they're adopted later in life, they're not the original context, but they're an early childhood context to understand the beginning of behavior, the seeds of behavior. That's the first thing. But secondly, you're somebody who hopefully, ideally, is going to be around for the rest of their life, and you can make a difference. And a parent is large in the child's mind. Doesn't matter if that child is 30 years old. To have a parent of a 30-year-old apologize to them or be accountable for something or recognize something or just have a different response makes a difference. I'm working with a 50-year-old woman right now, and some of her work is with her mother. And she's very successful career-wise, family-wise in life, but she's kind of at this midlife crisis. And part of what she's doing with her mother, she's having conversations that are healing at 50 years old. So Yes, you can. Yes, you can make some inroads. Yes, you can help the child separate out. Sometimes treating children without the parents present is to say, this isn't about mom and dad. This is about you. This is starting to become diagnostic now. Yes, that this may have been an early way for you to cope or to deal with the family dynamic, but now it's become a part of you, right? Now it has you. And now it's showing up in school when your mother and father aren't around. Now it's showing up at work or with police when your mother and father aren't around. And we can look back at your family to understand the context, to understand where it might have come from, how it might have started. But now it's about you and it's about life. And so yes, you can make inroads. And ideally, the more family support that you have in the process, the better. And then you provide the individual and the family with a sustaining relationship, right? Something that will be with them for a long time, long after the therapy is done. Next question. What technique can you recommend to advise and encourage a young adult with ODD? It's heartbreaking to watch him make the same mistakes repeatedly and difficult to deal with the angry, blaming fallout. Excuse me. Detachment is going to be key. I mean, even in your question, you can feel the angst, you can feel the pain. Taking a step back, it's important for parents to not make it about them too. They're not doing it to you. But that requires detachment to think that way, right? There's a great line in the book, The Knight in Rusty Armor, that we often refer to, where they say, what you do to protect yourself hurts other people. And that's really what this armor is about for the individual. They're protecting themselves from some feeling, some vulnerability, some emotion. And so detachment is key, taking a step back, doing your best to be able to see the behavior in the child, in the other, as about them and about their struggle. Remaining curious, right? So in terms of parental intervention, I think at the heart of it is that idea of detachment, healthy detachment, and not taking it personally. Right? That's the stance, the important stance. But and something important I want to also say, it's very important, fundamentally important, that you take care of you and that you set healthy boundaries. Part of what a child develops, this is very important, part of what a child develops as they grow up when their parent has healthy boundaries is an acknowledgement of an other, right? If my mother, if my father have needs and they take care of themselves, then I have to respond to that, right? I live in a context now where other people's needs are present, and it's okay, and there's no shame around that. So healthy self-care, healthy boundaries that are evidence of you taking care of you are critical. Constantly bending, constantly compromising, constantly shifting, constantly practicing poor self-care with somebody in this situation does not help them at all. And then there's another more subtle feature here, which is if the child just becomes a reflection of us, right? Evidence of our goodness, of our badness, evidence of our quality as a mother and a father. If that's all they become, if that's what we reduce them to, we are essentially reducing them to an object, right? So while it might look like loving behavior, it's really objectification in another way. So that detachment really provides a clarity of vision to be able to see the child. And that detachment, along with it, the necessary ingredient is healthy self-care and healthy boundaries. And requiring others in our lives to make space for that, right? To account for that, to account for us in the process. And if they don't, then we're going to take care of ourselves. Next question. It seems like identifying and acknowledging thinking errors of parent and child would be very beneficial. That's the cognitive behavioral piece. Yes, absolutely. The thinking error that is, I think a lot of parents, when they talk about their children's struggle, talk about it in terms of what you're doing to me. They're not doing it to you. That's a thinking error, right? There's a lot of other ones. There's rationalizing. There's projection. There's all kinds of thinking errors that therapy and others can help us to identify and help the family to identify. Rules and roles in families can be dissected, can be put under the magnifying glass and better understood and chosen consciously. Next question. Can you speak to how a young teenager, young adult with low processing speed, executive dysfunction can have symptoms that mimic ODD? My son's symptoms look like ODD. However, he has never been diagnosed with ODD. I have been told his stuckness or and irritability, lack of understanding, is due to a processing disorder. I mean, you obviously have a great understanding of it already. And it's kind of like I was describing earlier when I was reading the diagnostic criteria, when it says it can't be associated with other things like substance abuse disorder, with brain injuries, or with learning differences, like in your child. And so they're going to have a lack of empathy. They're going to have a lack of forethought. They're going to have a lack of recognition between cause and effect. All of that stuff that goes into processing and executive functioning. And so in those ways, it's going to be a lot more social training. You're going to have to adjust the context significantly. They're going to have to learn to advocate for themselves. They're going to have to learn to be aware enough to advocate for themselves, just like with any learning difference. And so I think for somebody like you and your son, it can be almost as frustrating, but important, just like with those who don't have the issues that your son has. It's critical that we take the emotional reactivity, the judgment out of it. We see the disorder as the disorder, as the disease, as the brain disorder. So in some ways, while it might be frustrating, the advantage that you have is that you can kind of identify it. And they're going to have some of the exact same kinds of things, but they don't even get to the same starting gate that you and I and others get to, right? They don't even get that. And so they can have a complete disadvantage. But again, some of the same principles apply, especially the detachment, especially not taking it personal, especially managing our own frustration and anger around the behavior, because that does not add, that loads heavily on the child and diminishes, in most cases, their capacity to do all the things you said your child is already struggling with. What type of therapist do I look for that will benefit my child's particular needs? I think my first kind of gut reaction is find somebody who struggled with some of this. Most of the therapists that we have at Evoke, most of the staff we have at Evoke have struggled with ODD, still struggle with it sometimes. And so somebody that can be empathic, somebody that's not going to take a simplistic moral approach to things, somebody that's going to have a youngness to them, if you will. It's going to give voice to the teenager. Somebody that the child can feel somewhat connected to, right? Not distant from. So they might think of them as cool. Something like that. So somebody that comes in young like that, somebody that's probably even going to feel to your child like a better therapist than maybe even you might think, right? They're going to be closer in personality-wise to the child. That's my experience of it. And I've been doing this now for 20 plus years. And the people that I've seen work the best with these individuals are these kind of young minds, these young spirits. They're in some ways closer to identifying with the child in this situation, this role, this relationship than with the parent in many ways. Not so far that they've lost contact with the parent side of things, but somebody that can definitely connect with the kid and probably has had some very similar struggles themselves growing up. Our child doesn't suffer from these disorders. She was just placed at a therapeutic boarding school. I struggle listening to my co-parent as he continues to focus on her symptoms, not what is causing them and what they are trying to tell us. We just had our first call with a new therapist, and I feel like we are starting over. I only have empathy for you. That's hard. Do your best to stay on your side of the street. Do your best to not let, and it's hard, but to not respond in such a way that it becomes about you. You know what I mean? The co-parenting broadcast, webinar, podcast is where I talk about that. So do your best to not become the issue. And do your best to focus as much as possible. Also, folks, I want to say this too. It's okay to ask for separate phone calls. I know nobody's going to like me saying that because it takes extra time, but it's okay to have separate phone calls if it doesn't work for you. And maybe that means you'll have shorter phone calls. But I was talking with somebody recently, like, stop doing co-parenting visits, right? Stop doing some of that stuff if it's hurting you, if it's not working, if it's triggering. If even by being together, you're being less effective as parents. So that's just a thought, an idea. I can't say that it applies to all of you or even to the individual asking this question, but I wanted to raise it because I think when young therapists get into this business, they think all parents have to do everything together. And my response is no, they don't. It's okay to separate parents out sometimes. Yes, there are times when it's effective that both parents are hearing the same thing and have the same message. But if it becomes such a distraction, don't keep doing it. People are divorced for a reason. Next question. Do most of these disorders last on average 3 years? No, not necessarily. They can last a lifetime. People can they can last a lifetime, but we're looking for at least 6 months before we're going to call it a disorder. One of these disorders. Do you see a pattern with impulsiveness in kids with ODD? Absolutely. It can, that can be a lot of things. But it can be impulsive. That can be related to ADHD or ADD. That can be related to poor executive functioning. So the answer is yes, and it can be indications of other things too. But sometimes when slowed down quite a bit, when put under the microscope, impulsiveness can be understood, can have a stimulus and response when we slow it down enough. We can see what's really going on. So there's a lot of things that can just seem like they don't, but I tend to always think, but let's find out why. Why that knee-jerk reaction? What's going on? What does that solve? So my answer is yes. Doesn't necessarily mean that that's only the case, and when you slow it down, you can still begin to understand some of the behavior if you slow it down slow enough. Can you please talk about getting treatment for parents only when the child in mid-20s is not willing to go to treatment? Is it helpful for parents to work on themselves only, to learn about addiction, family dynamics? Could it help on how to live with addiction? Absolutely. That's why we recommend the 12-step programs for parents. That's why we recommend Families Anonymous, Codependence Anonymous. Absolutely. Number one, it will give you peace of mind. But the ripple effect, folks, of you having peace of mind is also impactful on your family and loved ones. I believe in getting treatment for everybody. I believe most people, and I don't know if I've come across anybody that I think this doesn't apply to, but most people would benefit and do better in their lives with some form of therapy, some form of support. So absolutely do it, even if your child is unwilling. In fact, maybe specifically, maybe even more importantly, if your child is unwilling to get treatment, it's important to do it. Next question, is it important to always find the positive in all situations with kids in ODD? I don't know that I would say it's important to find the positive. I think finding strength, understanding that there's a strength there, understanding that there's a wisdom there, understanding that there's a function of the symptom there, will be helpful most of the time. So I'm not sure exactly what we mean by finding the positive in all situations. I think it's okay to talk about pain and sadness and hurt and difficulties and trials and struggles. If it becomes Pollyannish, if we lose authenticity in that. And that's that question, I guess, another aspect that question brings up for me is you need outside help. I have parents that become so focused on the negative and sarcastic and jaded that they can't respond to their child in a helpful way. I have other parents who bury their heads in the sand and can't look at what's going on with their child, be It's too painful for them to be aware of what's going on. And so, you help either side, either direction. You help them with that. So for all of you, I think it would just be about, again, talking to other people, talking to people at 12-step meetings, talking to a sponsor, talking to a therapist, getting some perspective. Where do you sit on this? Are you too far on one end of the continuum or the pendulum or the other? And sometimes we only can find that out, or most effectively can find that out with outside help. Are there therapies that work like EMDR, DBT, etc.? There are aspects of those. I mean, EMDR is going to work with trauma, and if there's trauma in this, then yes. DBT, there's some emotional regulation skills, mindfulness that can happen in there that can be helpful. It's not necessarily the therapies that the research says these are the treatments for oppositional disorders, but there are aspects, principles, tools, and skills from each of those that can be applicable, absolutely. Is our child the way she is because of the way we raised her? That's a interesting question. There's a dance there. You know, and I'm a family therapist. That's my training. I have a doctoral degree in family therapy. And we talk more about systems and dances and patterns, excuse me, than we did about cause and effect. So I'm not just alluding the answer. It's more complex than that. In systems theory, the whole is greater than the sum of its parts. 1 + 1 = 3. And so there's a systemic interaction. And yes, what I believe, what I know as a father, is that the most important work that I can do is to focus on my contribution to the problem or the solution. No matter what the history is before the child came to me, if they're adopted, no matter what their genetics are, no matter what the differences are in them individually, I'm most effective, I'm most helpful, I'm most optimistic when I focus on my contribution to the issue. But in order to do that, I have to get past and around shame. I have to get past and around guilt. Because if I am plagued by shame and or guilt, what I just said to you, my focus is going to be too threatening to me. So my answer to you is work on what you can. Work on your contribution to the dance, to the system. And if that triggers you to feel blamed or guilty or ashamed, work on that, because it need not be that way. One can look at one's contribution, one's dents that they put in their child without guilt or blame or shame. It is possible. But it takes work. And it takes unraveling some of our own family of origin messaging and ideas. When a teen has ODD or CDD, how much do the friends influence them and their behavior? You know, and during adolescence, friends become important. But that's an interesting point, because one of the things that friends offer individuals who struggle with these themes is unconditional acceptance and even reinforcement. That's why it's so important for us to detach and to have less judgment, less reactiveness, right? So that we can be better situated to be there in their lives. When you add that guilt, that shame, that intimidation, that judgment on top of it, that's why so much, folks, in the treatment of substance abuse disorder, we talk about it being a disease. It's a great way to remove the judgment out of it. And these could be seen as brain diseases also. So when you can look at it as a disease instead of a willful moral failing, then you respond to it differently. And you respond to it ultimately in a more helpful way. So that's the role that friends, it's important for us to see the benefit, the draw to the friends, and to see where we can, if possible, replicate that same reward, right? We're not going to be their friend, I'm not saying that, but if we can find ways to meet those needs in our children in ways that we can feel good about, then we can take up more space in the child's mind, in the child's life. But adolescence and young adulthood is a time for exploration in other relationships. It is a time for separation, right? Another thing that I didn't talk about tonight is this idea that ODD is kind of this broken process of separating from parents. It's a maladaptive separation. So teaching people how to separate in a healthy way can be an important task for both child and family in this process. Next question. It seems that mostly people are referring to their son. Will the symptoms of ODD and especially conduct disorder manifest differently in a young lady? Is it more prevalent in boys, or just that boys are most likely to be diagnosed because they have more physicality than girls? I don't know the odds off the top of my head, so I'm going to speak anecdotally. So I need to say that so we could look up the research, because I didn't look up that tonight. My experience is that boys are more demonstrative, typically. That it's more likely that a boy is going to act out. In my experience, again, anecdotally speaking, our female clients tend to act in, right? So while boys might be more angry, lash out more, and even the norms in boys and girls, right, are that boys can be more demonstrative and be seen to be healthy, and if girls are acting out, we have words for them, right? So they're socially, they're punished for acting even in ways that boys do, even in our society. And I think you know what I'm talking about. So there's a societal pressure, there's societal filters, and girls do tend to act out in my anecdotal experience, act in my anecdotal experience, and boys tend to act out. It's the exaggeration, if you will, of the masculine. My son is at a Voc and has been surpassed by two others in the phase work who have been there less time than him. He is diagnosed with ODD, and because of his slower progress versus others, he has lost motivation. Yet he doesn't see the actions of shutting down or communication less now, and is getting his own way. With his ODD, I am concerned that he's hit a wall and is not going to move through the phases, and ever genuinely see his issues and learn the tools to get out of his own way. I believe he is holding his breath until he gets to the other side and leaves, and he won't learn the skills and feel and to feel and channel his anger. You know, that's a good question, good point, good concern. I guess it's a concern. I would have to defer to your therapist very specifically, because I don't know your son's therapist. Part of my thought is that his lack of progress, one of the functions of that is to get you to lose hope. Okay? So be careful, because I've seen this a lot with our clients, is that they want parents to give up and lose hope. And so as much as possible, listen to the therapist, listen to their directions, but be curious. And sometimes people have to get to a new low before they're ready to change, before they're ready. It has to be more uncomfortable for them to try something. And so his struggles, from your brief description, his struggles don't fall outside of what we're accustomed to seeing. So listen to the therapist. Be aware of the fact that part of the intent unconsciously of the behavior could be for you to lose hope. And so take some distance, right? Take a pause, take a step back. Hold on lightly to him and to his progress. Is there a connection between high ACEs score and ODD? I'm not sure of that. I do know that well, I just don't know about that. I can't answer that. So I'm not going to go anymore. This is an off-topic question. My son will be leaving boarding school for college in June. He'll be using the disability services at the school for ADHD and executive dysfunction for accommodations. I've just sent him an email with his testing results, psych eval. He does have support at his school to review with his therapist. However, it is a very in-depth, and I'm concerned that of the effect it might have on him. It was done by a certain therapist. You briefly mentioned earlier, you do not usually share testing with clients. I'm concerned I'm opening a can of worms. My opinion is to trust the therapist to deal with it judiciously and to be very intentional about it. Defer to them. I've seen my testing when I was an adolescent. It didn't leave a lasting mark. I saw it when I was younger. I think it's something that he needs help processing. And like you said, if he's going to use the disability services at his school for accommodations, it's important that he knows some of that, right? We all have strengths and weaknesses. We all have proclivities. We all have themes and patterns in our lives. And if we can deal with that stuff in a mature, psychologically sound way, we can be wiser and more effective. So I would rely heavily on the therapist that's treating him. Can you recommend any good books on these disorders for further learning? If you go to, let me just take you to this. One that comes to mind is Raising Cain is one that we've used. But if you go to the Parent Alumni Foundation book page, we have a section on oppositionality. So you can look at the books that have been recommended by therapists there. All right, folks. Got to wrap up. Thank you for all your questions and interest. We want all parents to go to 6 12-step meetings. Al-Anon, CODA, Families Anonymous, Nar-Anon, or Al-Anon. You can also go to NAMI.org for resources in your area. You can follow all of our broadcasts on a podcast app. You can go to the podcast app on your iPhone or your iOS device, or go to the SoundCloud app on your Android devices. Follow us on Twitter and Instagram, Facebook. You can also go to the Alumni Foundation page on Facebook. My book, and like I said, all the other books that have been recommended by a therapist are available through the Amazon Smiles program, and a percentage of the proceeds goes to charity. Parent support groups coming up. We have one in Los Angeles on March 26th. Contact Andrea at evoketherapy.com for more information. That's a Sunday afternoon in Los Angeles, and the following evening in Muirwood at the IOP there. We just finished the workshop at the Cascade, so the next one is in May at Entrada. We want all current families to go to the workshops. The Finding You is coming up this Sunday. I believe we're full with that. We might have one spot. If you have any questions, you can email intensives@evoketherapy.com. And then the next ones after that are at the end of April or the end of May. These are deeper, more personal, small groups run by myself, if you want to do those. Pursuits trips are for family or young adult fun, high adventure, therapy light. The next webinar will be this Thursday, the 16th at 7 p.m. Mountain Time, and we'll be talking about emotions. Thank you so much for this evening. I hope these points of contact are helpful. It's good to be back. Take care, folks, and I'll talk to you Thursday night. Bye-bye.